It's good to be back with you again as a rookie just starting out in trans-radial approaches to have Dr. Sato, one of the world pioneers, and Dr. Patel, who's sort of been my mentor through this learning process here, is a very good experience. Um, what was it that actually got you? I know you were a very busy femoral operator, and now you're a tremendously busy radial operator. What was it that made you initially convert from femoral to radial angioplasty?
Okay, I started the transradial approach from 1995, so back to 8 or 9 years ago, just after I visited Taiwan. And I went to Kaohsiung. Kaohsiung is a big city in the south part of Taiwan, and there in that hospital, the
Right.
Dr. Wu was working, and I actually I went there to teach some stenting technique, and but I saw that in that hospital they were doing transradial approach, but it's not for PCI, but for angiography diagnostic. But anyway, I knew that even for Chinese people, we can do from the radial approach because of course the Dr. Kim Ne started the transradial approach in 1991 or two, and so I knew that there is this approach there was, but I could not imagine that this approach was also feasible for the small built Oriental people.
Yes.
Anyway, they were doing in Taiwan. So after coming back to Japan, I pronounced to my young colleague doctors, we switched to the transgender approach completely. And initially, the young doctors did not agree with me, but I ordered. I changed.
So there's still some cases that you would do from a transfemoral approach.
Yes, because in Japan we are doing a lot for chronic total occlusion,
Yes.
and in some cases for chronic total occlusion we need bilateral
Okay.
angiography, and for that case the transfemoral approach is convenient.
And Dr. Patel, I obviously came to learn from you to do the transradial. What was your stimulus? How did you get into transradial angioplasty and angiography?
Yeah, Professor Capola, it is a very interesting story. Like, I am doing my interventional practice way back since 1992, and I was fine with femoral approach, and I was doing the angioplasties and interventions very aggressively through that route. The turning point came when I lost two patients in the year 1999 consecutively in 1 month. The first patient after coronary angiogram, unstable patient who bled through the groin, developed hypotension, and then unfortunately that lady had anterior wall MI, and before we could do anything she died in the medical ICU. The second patient, after a good multivessel intervention on a full dose of Riopro, developed sudden unexplained hypotension at night. We could realize that it was retroperitoneal hematoma. We tried to treat it. Ultimately, patient developed renal shutdown. Patient had to go for multiple hemodialysis, developed septicemia, and we lost the patient. Losing two patients consecutively in 1 month time was literally a shocking affair for me. It was a shock to me. So, uh, after losing these two patients, I introspected that with myself that there is something which really needs to be done, because I had no reason to lose a patient after a simple angiogram or even after a multivessel intervention with a very clean result. We went through the literature, and whatever little material was available in the literature, I could find out with few randomized studies which were published. I could find out that radial route has 0% major vascular complication rate. And then of course it reminded me of Dr. Saito, whom I knew since 1994 during our mitral valvuloplasty days, and I knew that he is one of the world authorities for radial. And I approached him, and it was very nice and kind of him to accept my invitation. He came to my place for 4 days, and we did about 100 cases, and we knew what exactly were our problem. And again, we decided, and we were very firm that we have to be radial operator, whatever may be the problems, and we slowly overcame our problems, and we became radial operator. And again, the same thing, like we have to do 100%. That was again an order from my side to my colleagues. Nothing like 50-50 or 30-70. No. If we do radial, we do 100%, because then only we know what exactly are the problems, and we accomplish the procedure, and that is what exactly we did.
All of us who are in interventional cardiology have had similar experiences. I can think of 1 or 2 patients that I've lost over the years because of femoral complications, and doing the quality assurance for the catheterization lab here, we do about 1,500 interventions a year. There are usually 1 or 2 patients who will end up dying because of femoral complications. As you say, sometimes it's not acute, but a slow, chronic problem, from the bleeding to hypotension to renal failure to sepsis. And I think the thing that started me on my path to India was that someone had mentioned to me that there's Dr. Tejas Patel in Krishna, who's done over 6,000 cases with 0 transfusions. And that alone perked my interest. I think that there was a certain fear of learning the technique, and a fear of, was it painful for the patient? Is it very difficult to learn? And I think that coming to Krishna and spending a week, and we did 100 cases in that week, was a great learning experience, and prompted me to come back here and start to convert over to a radial program. And certainly, I don't think I have the same control that you and Dr. Sato have of the lab, but I think that by example, many of my colleagues are switching over to a radial approach. Certainly the high volume operators, and I think that the patients and the doctors are enjoying it more.
I think it's a very interesting observation I think we came across. Like, we started radial program keeping, the elimination of major vascular complications in mind. But by establishing the program as a byproduct, we bought so many things, like patients' compliance, terrific. I mean, they loved this procedure, because particularly those patients who have already undergone femoral procedure before, they could differentiate absolutely between these 2 procedures, and they loved it. Secondly, no urine pot, no bedpan, nothing, that made their life so easy in medical ICU. And very early discharge in less than 24 hours time. At times we do in the morning a clean case, and patient takes supper with the family in the evening. And it made the procedure very popular in our area. We are talking about the advantages to the patient, the comfort level to the patient. But our medical ICU and cath lab staff, the nurses and techs, and the ICU nurses, and even the ICU orderlies, and the infrastructural staff, they were so happy with this procedure. Like, they don't have to struggle much at the night, and the patients were complaining less and less, practically nearly 0% complaint rate from the patient's end. So mentally also they feel so good. So the whole environment becomes, rather than being a very heavy environment, it becomes a very casual and cordial environment. So that was, I think, again a very major advantage.
We've seen a couple of patients who have said, no, I want the doctor who can do it through my arm instead of my leg. I think as more people start asking for a procedure done in a particular way, I think you're going to get more doctors either getting more hostile or deciding that they want to learn how to do the technique to oblige their patients. So I think that one of the other big issues that drives things here is cost, and by making it easier for the nurses to take care of the patients, you don't have to have such an intense nurse-to-patient ratio, so that makes it a little bit more cost-effective for the hospital. And many of the closure devices that people use for transfemoral are relatively expensive. They can add $200 to $250 a case, and in a large volume laboratory, you're talking about $250,000 a year in additional costs. So, and they don't work 100% of the time. There's a significant rate of device failure, and that device failure leads to bleeding and hematomas.
Yeah, actually, complications increased.
Right. Yes. Yeah. So I think that very often the transradial is done for different reasons, but as far as the hospital administrators are concerned, it's actually much more cost effective, and they're happy about that.
I think the major problem with this particular procedure is it has become popular in certain pockets of the world, like Japan, certain areas of Europe, like France, part of Germany, some parts of Italy, some parts of UK, and in Asia, like in India, we are trying to make it popular. Unfortunately, it has, up till this date, it has failed to mark a dent in the United States. The day it takes off in the United States, I think the acceptance will go up all over the world. And Professor Coppola, I think now you have already set the ball rolling in the heart of New York, in Manhattan, at your hospital. I see a bright future of this procedure down the line in coming 2 to 3 years.
Thank you.
Globally.
I certainly hope that we can encourage other high-volume operators to pick up on this technique. I think that one of the things that limits the technique here in the United States, and probably also in India and Japan, is that there are some people who are low-volume operators who are maybe doing 50 or 60 diagnostic catheterizations a year, and I think for them it's intimidating to try to learn a different technique. But I think that the high-volume operators, once they realize the benefit to their patient, will pick up on this, and maybe part of it will be the market pressure when they start losing patients because the patients are going to the doctor who does it through the wrist.